Welcome back, everyone, to the morning session. I know people are still dribbling in, but we're already running a few minutes behind time, so it would be really great if we could get going. Welcome again. I'm having such a fabulous day. Wasn't that session this morning just wonderful? It was so great to hear that kind of longitudinal perspective and then where we can be going in the future. So I want to thank all the panellists and Normal Swan, and then Rachel just mapping out where we're at with the drug trends that are contemporary. So this morning session, we've got a great session for you as well. It's called Alcohol Policy and NDARC Spotlight Presentations, and we've got a fabulous international speaker with us today who's come all the way from Scotland, Professor Sharon Hutchinson. And she is going to be talking to us on the importance of an evidence-based approach to eliminating hepatitis C and implications for tackling wider drug-related harms in Scotland. Before I introduce her, I'm going to remind everyone that we have an opportunity for questions. So you can either use the Slido, and we've got an iPad that I'll be keeping track on those questions, but also there's a couple of roving mics. Morgane and Kamal will be bringing them around to you. So if you've got some questions at the end of this presentation, please post them for us. So Sharon, and I promise not to read every single word on this, Sharon. So Sharon's a Professor of Epidemiology and Population Health at Glasgow Caledonian University and Honorary Consultant with Public Health Scotland. Her epidemiological research involving population-based surveys, data linkage studies and statistical economic models focuses on the evaluation of interventions to prevent bloodborne viruses and related harms among people who inject drugs. Thank you, Sharon. The stage is yours.
Thank you very much, Nadine, and thank you to NDARC for inviting me to come along and present at your conference today. It really is a pleasure and a privilege to be here. So I've spent many years trying to generate an evidence base for how we go about tackling hepatitis C. So I'm going to give you the latest that we have on efforts to eliminate hepatitis C, and also how we are then adapting this evidence base in our systems to inform efforts to prevent other drug-related harms. And for those of you who are not familiar with Scotland, I've just summarised the context here. So we're relatively small country, just over 5 million people. We have a devolved government in Scotland, so things like health are devolved to Scotland, the responsibility of Scotland, but other things such as law, drugs law, are reserved for UK Parliament. We've got an estimated 40 to 50,000 people that are dependent on opioids. So that's a relatively high prevalence of individuals. Less clear on estimates of people who are actively injecting drugs, but these could be in the range around 15 to 20,000 people. And we have a high proportion of that population are living in this area of Glasgow, and indeed even a higher proportion of the drug-related harms are centred in this Glasgow area. So for hepatitis C, for example, 40% of people with hepatitis C would reside in around this Glasgow area. And Scotland, of course, hits the headlines. We have the highest drug-related death rate in Europe. We've also had one of the largest outbreaks of HIV infection among people who inject drugs in the UK for over 30 years. And that is actually despite reasonable coverage of harm reduction services. 2/3 of those opioid dependent are on OAT. And we've got a fairly wide coverage of needle syringe provision across the country. So I think I like to revisit this piece of work that we did now more than 10 years ago. It's work that Natasha Martin at Bristol at the time led on with partners across Edinburgh, and Melbourne and Vancouver as well. And this was about trying to predict what could be the potential impact of the new therapies for hepatitis C, the DAAs, when they were going to come in around 2014, 2015. And what this demonstrated in different settings, there was real potential with the new therapies to drive down infection levels. Regardless of where the baseline prevalence was, you could still, with varying levels of treatment uptake, drive down infection levels. And I remember presenting this at the time to a whole range of clinical audiences, and it was met with some skepticism at the time. One, in terms of, well, are you going to be able to reach that population? At the population level, can you reach them? And would infection levels, if you could reduce it within treatment, would it not just increase back to where it was? So it's nice to now, 10 years on, have data now to actually demonstrate the impact of scaling up DAA therapy among people who inject drugs. And these are data from countries, of course, that have been very proactive at scaling up hepatitis C treatment to people who inject drugs. And these are data from large population-based surveys of people who inject drugs. In Scotland, we refer to as NESI, Needle Exchange Surveillance Initiative, and we go out to over 100 services, low-threshold services providing injecting equipment across the country. And through that, we can really track progress on where we're at with tackling hepatitis C. And you can see we're getting to reducing infection here by about 60% in Scotland, and even higher reductions from similar surveys in rest of the UK and Australia. For us in Scotland, we actually we recruit a large number of people through this survey, so 2,000. That's actually a relatively high proportion of the total population who are injecting drugs, in the region of 10 to 20%. So it means that we've not got just good data at a national level. We've actually got very good information even at a local level, and that means that this survey is particularly helpful in guiding action, not just nationally, but also locally. So how have we done that? How has treatment been delivered in Scotland? And this was a feasibility study that Matt Hickman and I worked with partners in Tayside, John Dillon, to try and demonstrate whether it's feasible to majorly and rapidly scale up DAA therapies to people who inject drugs. So this was done through a range of services that are engaged with people who inject drugs, pharmacies, drug treatment centres, prisons, services giving injecting equipment, using dry blood spot testing, which had been introduced many years ago through an action plan. We adopted that approach many years ago. Also, a team of specialist nurses across the country that could coordinate the delivery of treatment in all these settings. Our aim through this project was try to reduce the infection levels of 30% originally, around that mark, down to 10%. And here are the data from our survey. So that this treatment was scaled up in all of these settings, and you can see by 2022-23, then a vast majority of people that were eligible for treatment had been treated among people who injected drugs. So it answered that key question: can you reach that population who are injecting drugs? And yes, indeed we can through this sort of approach. In terms of levels of infection, here, baseline around 30 or just above 30%, and by just before we had lockdown for the pandemic, indeed we met our aim to reduce prevalence in that population down to 10%. Now, of course, during the pandemic, testing and treatment levels reduced during that pandemic period. And so there was a wee bit of nervousness as what we're going to observe when he come back through and got the survey back up and running. And here we now find even lower levels of infection. So testing and treatment has been maintained, and we're able to demonstrate even lower levels of infection in this population. And then the modelling work as well on the far right here demonstrates that not just prevalence, but incidence, that's the rate of new infection in the population, we see that also declining with the scale-up of treatment and the reduction in the prevalence. So that has been really where a lot of our efforts have been in recent periods, is to look at how we evidence progress on elimination according to these WHO metrics. And I think WHO still need to be persuaded that incidence tracks prevalence. So they want evidence on incidence as well as prevalence. But this is more difficult to kind of measure through directly through surveys or even cohort studies. It's you'd need very large initiatives to really track progress on incidence, and that's where we've been developing a range of modelling studies to try to estimate incidence of new infection in this population. Here, this particular initiative is looking first at our survey data. This is our NESI survey, of which we have information on each cross-section. Every time we go out and do a survey, we'd have information around their antibody status, their RNA status, so you know how many are chronically infected here, antibody positive, RNA positive, but you wouldn't directly know of those if they're long-standing infection or whether they're new infection, first-time infection, or a new infection with reinfection. So that's the job of the model, to try and bring in the information together to try and estimate within those that are chronically infected how many are new infections and how many are long-standing infections. And from that, you can then estimate incidence. And these are the data here that we generate from the model. So this is work that Scott MacDonald has been leading on, and it's under review at the moment. And we see back to the start of the very early rollout of DAAs here in 2015, 2016. We're estimating around 6 to 9 new infections per 100 years within that population. There's some uncertainty here in reinfection rates, which is to be expected because you have less people that would have been treated and cleared infection at that time, so more uncertain here. But as you can see that these incidence rates, as the treatment is scaling up and the prevalence is reducing, then as you would expect, the incidence rates are also coming down. An interesting reinfection, which initially we estimate was higher, that is also now coming down in this population. And this is the WHO target here, the 2 per 100 person years that we're aiming to get at. So this evidence would suggest we're coming very close to that WHO target. This is for a population of particularly high risk. So we're recruiting people who are engaged in drug use, actively injecting drugs in the main. And so these incidence rates are actually quite impressive that we can get it down to these levels in a population that is actively injecting. The other approach, which is similar to the work that Natasha Martin had done many years ago, a mathematical modelling approach to try and simulate transmission within the population. And here, this is broader in terms of the definition of people who are at risk, and we use the cohort, or the denominator population of people who are dependent on opioids. So we have got estimates on that, which we can help to parameterize the model. And the good thing about these models is that you can not just check where you are currently in terms of estimating incidence, you can project it into the future if you continue levels of treatment at the same rate. So this draws on all of our data from surveys and other administrative data. And here this shows, on the left-hand side, shows the scale-up. These are the actual numbers of people that have been initiated onto hepatitis C treatment through a range of sources here, either in prison settings, people who are in drug treatment settings, and other community settings as well. And you can see that the scale-up was particularly Much of that happened between 2015 and before the pandemic in 2020. Still continuing treatment, but not at the sort of levels we saw pre-pandemic. But, you know, the pool of people that are infected now is shrinking, so that's always going to happen. And here, this is the prevalence of infection, and you can see these are the observational data from the surveys, the dots here, and the model is calibrating pretty well with those observed data. And again, we can generate, well, what's the incidence of infection? This is both primary and reinfection. And similarly to the last modeled estimates, we see as treatment scaled up, and prevalence comes down, you see the incidence of infections come down. So this is work led by Badisha Kudu and Peter Vickerman and others at Bristol, and it's provisional at the moment, but I think we're reasonably confident we'll certainly be on track to eliminate HCV infection ahead of the WHO target of 2030. Now, there is a danger with the word elimination and efforts to eliminate that people, once they get closer, achieve that target, there'll be policymakers and practitioners might be switched off to that. So certainly in Scotland, we've been looking very closely at our testing rates and some key population groups here in prisons here at the top and amongst OAT clients. So this is done through record linkage. We can link up the data to the testing data. And you can see that even though we've got guidance around opt-out testing in prisons, we still have actually quite a low proportions of people that are being tested in prison settings. And similarly for those in OAT, we get up to around 40% of clients coming through OAT services that are also getting tested. So recently, Scottish Government has adopted targets within these settings to really try and scale up testing in these settings. So if I can move on now to efforts to tackle drug-related deaths. So you'd be familiar that Scotland has one of the highest rates of drug-related deaths globally. Here you see the numbers of drug-related deaths were creeping up year on year and then really rapidly accelerated from around 2014. And that was actually coincided with the HIV outbreak in Glasgow along that time, which is associated with a shift to cocaine injecting. Before then, heroin injecting was the main drug for many years. And so, interestingly, although we had this escalation in the numbers of people that are dying from a drug-related death, what we continued to do was just characterize actually the numbers, the people who were dying. We weren't looking at the risks within the wider population that were at risk of drug-related death. And as a consequence, the narrative that was emerging was that this was an aging cohort, and this was an effect of that, and it would be happening regardless. So in the absence of having other intelligence to understand the risks of drug-related deaths in this population, we looked at our hepatitis C data, because we had for many years been linking our hepatitis C diagnosis data with data on deaths and hospital admissions. And so this was really helpful to show that these are drug-related mortality rates over time according to different age groups. And yes, the older age groups certainly do have a higher risk of mortality, but so do, you can see this increasing amongst the younger group as well. So age and cohort effect wasn't solely responsible for the rise in drug-related deaths that we were observing. And then it wasn't until the COVID pandemic where we had an opportunity to start linking a whole range of data, and indeed we were able to draw on information from our national prescribing information system here on people that are on OAT to create a cohort initially to look at the direct impact of COVID, but then to look more broadly at the indirect effect on other drug-related harms. And very quickly, these are just some of the data that we pulled off during the pandemic, and we did this at a pace that you wouldn't normally be able to do out with a pandemic period. So you could pull all of this together within a matter of 2 to 3 months and look at vaccine rates. Here, we looked at vaccine rates amongst the OAT cohort according to matched age, sex and socioeconomic status controls. And we saw that during the pandemic, we got a gap between the OAT cohort having lower vaccine rates compared to these matched controls. And that was a gap that grew over time and helped to show that we couldn't expect that these individuals would go into the big vaccine centres and that you needed to embed vaccination within the services that are engaged with people who inject drugs and also do further outreach work. So this is the cohort that we've got on OAT here. We've got very stable rates on OAT in each of these periods, around 33 to 34,000. It is indeed an aging cohort from 36 here up to 42. The methadone has been the main OAT for many years, but there has been a shift in more recent period, particularly with injectable buprenorphine that has come in as well. And again, so now that we've got an OAT cohort that's linked to deaths and other data as well, then we can replicate the analysis that we did for the Hep C cohort, just to corroborate here that this was not an aging cohort effect, that we got rising drug-related death rates across all of these age groups. Of course, aging is still a contributor. The older ages are still at higher risk, but it's not the sole factor that's underpinning our rise in drug-related deaths. And here, because this cohort, if you place it in the context of the international literature here, Sarah Lani's meta-analysis, these studies at the bottom have the highest rates of drug-related mortality, and you can see that we are very much placed at that end of the spectrum with these latest data from Scotland. So what's causing this rise in drug-related deaths? It's not an aging cohort effect alone, and work that Matt and others, the team at Bristol, have been doing in terms of estimating the prevalence of opioid dependence, again, through looking at the cohort of people that are on OAT, those that are on OAT and off OAT, and you could look at the rates at which they incur events of opioid-related deaths, or opioid-related hospital admissions, and then you could look at the events that are out with this cohort and make some estimation about the wider population that are out there that are opioid dependent and are not on OAT and not been on OAT for the last 5 years. And what you get is that the prevalence of those people that are known in OAT for the last 5 years, it's a very stable, remarkably stable population, around 1% of the population. And these are the overall estimates from this modelling work. And this does not suggest that the population has increased. That would suggest an account for the rise in drug-related deaths. If anything, there's a suggestion that this is declining. So is there something to do with OAT treatment then? And you see here, these are the rates of drug-related mortality for those that are off OAT. This is the red line here. So higher rates here for those that are off OAT, and lower rates of drug-related mortality for those that are on OAT. So OAT is, as you would expect, is highly protective. We get a very good effect size here. But what you'll also notice is that for those that are on OAT, you still have a rising rate of drug-related mortality in that population, despite being on OAT. We have updated this analysis, particularly for the COVID period, because other settings, particularly North America, saw a rise in drug-related deaths over this period. We've seen a plateauing in our drug-related mortality over that pandemic period. OAT remains highly effective. And it may be because we already had very high coverage of OAT before the pandemic, and obviously a lot of work that was done early on in the pandemic to ensure people stayed on OAT as well, that helped to avoid a rising drug-related mortality rate. We've looked at other outcomes, such as suicide. So suicide, this population, the OAT cohort, are particularly high risk of suicide, 7-fold higher risk than when you compare it to general population controls. Again, similar analysis. These are the top line here, people that are off OAT. The bottom line are those that are on OAT. You can see there's a gap there. OAT is highly effective and protective against this outcome of suicide, and also what you'll notice here, which I find interesting, is that there's a general downward trend over time. So that's in sharp contrast to what we have for a drug-related death, where we have a sharp increase in drug-related deaths. So I think a lot of the evidence at the moment is pointing to the substances that people are consuming and the number of substances that people are consuming that are driving with this rise in drug-related deaths. And here are just the national reported figures from NRS here, showing opioids are still involved in the vast majority of drug-related deaths, but you see this rise here in benzodiazepines, and also you see this dashed line here in cocaine as well. Was it the other way around? Must be the solid line. Amongst any benzodiazepines, you see that the vast majority of them are street benzos that are also contributing to a drug-related death. So at the moment, we're doing some further work to try and untangle this. We've got very good data on prescriptions and whether people are being prescribed benzodiazepines. We can look at that over time. This is work that's being currently done by Megan Glancy in Glasgow. We've got some information on illicit benzodiazepine use, although it's not over time, it's baseline information, and so we're really stretching the boundaries of what you can do with multiple imputation to address the gaps in data. But early evidence suggests that certainly for those that are off OAT, there are higher risks of a drug-related mortality for those that are prescribed benzodiazepine, and particularly for those that have also got evidence that they have previously used illicit benzos. So we don't have great administrative data on illicit use of these drugs, and that is a gap in our intelligence, and we need to really improve that. We've got data from our surveys, which have already shown that a very high proportion of people injecting drugs that are on are taking street benzos, around half of them. It's related to sort of factors that we'd expect that puts them at higher risk, including recent public injecting, frequent incarceration, and so on. And even if you adjust for all these factors, then the use of street benzos is still 2 to 3-fold higher risk of an overdose. This is non-fatal overdose because these are people that we interviewed, but there is evidence here. And people report using these street benzos, but of course, and often it's typically street Valium, but of course, they're not aware of what is involved in the drugs that are taken here, showing a number of substances that are they're found in these tablets that typically look like prescription drugs. This is a real area for us to pursue in terms of safer consumption. We have, of course, got the first safer drug consumption in the consumption room in the UK that is opened in January in Glasgow, but that is only one service in one part of Glasgow, and clearly that is not going to tackle the rise in drug-related deaths across the whole of the UK. So we need other approaches. So just to summarise then, I think hopefully convinced you that the public health surveillance data that we have had that have been very much geared in order for us to prevent key infections, hepatitis C, HIV among people who inject drugs. These are now being incredibly useful to try and help us to better understand the rise in drug-related deaths, and only then can we then properly inform efforts to prevent drug-related deaths in the population. Scotland is on track to achieve elimination, but we need to make sure that by doing so we don't switch off all of our progress, and we need to try and maintain, particularly testing in key settings, I would suggest. And drug-related deaths are starting to plateau in Scotland, but they're still incredibly high. There's a lot of work to be done to try and inform where efforts are placed going forward. OAT, highly protective, but on its own is not, as it stands, sufficient to tackle the rise in drug-related deaths. Thank you very much. Oh, all of my acknowledgements.
Thank you. Thank you, Sharon. That was really, I found it very moving. I mean, Hep C, the direct-acting antivirals for the treatment of Hep C really is, I think, one of the biggest medical advances in our sector this century. And I mean, we all remember some of our important colleagues in the sector that it was too late to help, but just that now that we have something to offer people and people are coming forward for treatment, it's really changed the landscape enormously. So that's really exciting to see that data there. Not so exciting to see the contribution of benzos and novel benzos to death. Someone had, yeah, Jason, you've got your hand up. I don't have the Slido.
Jason Grebley from Curry Institute. So fantastic talk, as always, Sharon. Look, you and David Goldberg, you know, were actually some of the global leaders in the early days of hepatitis C in generating some of the evidence that was required to convince the government to actually fund a national action plan for hepatitis C. And not only did you get the strategy, but you got the government to commit to funding to implement, which was amazing. And I guess just tying this to the discussion this morning, have you had much in the way of discussions with the Scottish government around plans for future national strategies and potential implementation of national strategies on the drug use side?
Yes, and I would say that continues to happen on the infection side. So I don't know how it works in Australia, but certainly tackling the likes of hepatitis C, HIV, other infections sits within health protection and health, whereas the other tackling drug-related deaths and other drug-related harms, it doesn't sit within the same portfolio. So, and I think that we need to try and join that up a bit better, because we can actually learn a lot from how we have responded to these epidemics of HIV and hepatitis C. So I think there's much to learn from that. So we've got, because of all of the, we got Scottish government on board very early on hepatitis C, and much because of they recognise this affected people in the poorest parts of Scotland. You don't get another condition really that has a deprivation profile like what you do for hepatitis C. We compared it to other conditions, and Hep C was off the charts in terms of it really affecting people in the most deprived populations. And that is something that helped us in persuading Scottish Government to really focus efforts initially on hepatitis C. It might be different in other contexts, how you do that, but you've got to find the political lever, if you like, to get them on board with that. So there's a lot of infrastructure there, particularly on the health protection side, I think, in terms of, you know, doing incident management responses, pandemic responses. There's a lot of infrastructure that goes with that. So when we produce a lot of this data, we don't wait till it's published. We present it immediately, and there's a discussion in all of these forums. I think a similar thing needs to happen for drug-related deaths. I think there are discussions, and there's different groups, but it's perhaps not as coordinated as it is on the infection side. So I think we're still at early days in terms of trying to bring a lot of the evidence that we're getting on the drug-related death side to inform efforts to tackle drug-related deaths. And we've had to obviously pursue lots of different routes to get funding, and that all takes time, which we haven't got time at the moment, I think, for tackling it. So I think we're doing these sort of talks, and we're doing these talks in Scotland and the UK as well, to try and stimulate a similar approach like what we've had for hepatitis C to tackling drug-related deaths. And it's interesting, actually, we've now got the drug minister in Scotland that used to be the public health minister and is very well versed in hepatitis C. So I'm hoping that she's going to be all ears for this.
Thank you. Thanks, Sharon. I think we're going to have to move on to our next speaker, but Sharon will be around. I'm sure you'll take questions personally if you want afterwards. Thank you. Our next speaker doesn't really need introduction in this forum. It's Associate Professor Amy Peacock. She will be taking both presentations because Mia unfortunately couldn't join us today. So Amy is an Associate Professor and a Deputy Director of the National Drug and Alcohol Research Centre and an Adjunct Researcher at the School of Medicine in the University of Tasmania. She's also currently the Program Lead for Drug Trends. Amy's come all the way from Tasmania, not quite as far as Scotland, thank you. And Amy's going to be talking on how can monitoring off-premise alcohol pricing inform best practice alcohol policy in Australia, findings from a pricing surveillance system, and evaluating the impacts of the repeal of the Northern Territory minimum unit price policy on off-premise alcohol pricing. So thanks, Amy, over to you.
Thanks for the introduction, Nadine, and apologies everyone that you get an unexpected double dose of me today. I'd like to start by acknowledging the Gadigal people of the Eora Nation and the traditional custodians of all the lands on which we live and work. I pay my respects to elders past and present and extend that same respect to all First Nations people here today. The work that I'm going to be presenting on has been supported by a range of funding sources, in particular New South Wales Health. I'd like to acknowledge all of their contribution and also acknowledge the contribution of the fantastic team that I'm representing today, in particular Mia and Dr. Nicola Man down the front here. So, as we all know, alcohol is a major contributor to premature death and disability globally. It's linked to over 200 health conditions, and for Australians, it costs us $73 billion each year. And alcohol pricing is a key driver of harm. The lower the prices, the more they contribute to increased consumption. And it's really the cheap, high-strength alcohol that we see fueling the heaviest drinking and the greatest harms. Taxation and other alcohol pricing strategies help to reduce consumption across the whole of population. And indeed, we see the World Health Organization call pricing policies a best buy in terms of being the most effective and cost-effective strategies to prevent alcohol-related harm. However, in Australia, unlike most other countries globally, there's no requirement for alcohol industry to collate and share data on alcohol pricing practices, or indeed to share information on alcohol sales in Australia. So that leaves us in a bit of a tricky situation where we have no reliable information in terms of informing and evaluating what happens with our alcohol pricing policies. And this is despite WHO strongly recommending that countries have the mechanisms to be able to assess pricing practices. So we've been working to try to fix that. While most alcohol purchases occur in physical bottle shops, we have seen this shift towards retailers selling alcohol online. And the prices online generally reflect what we see in store, and they're publicly visible, they have a great degree of information about the products that are being sold. So in 2023, we ran a pilot study where we demonstrated it was feasible to obtain detailed information on the alcohol market from these platforms. We captured over 80,000 alcohol listings, over 3 data collection points, and from 5 main retailers in New South Wales. Luckily, we've been funded by New South Wales Health to continue to collect that online data on a quarterly basis across these 5 main retailers in New South Wales, set to stores in 1 capital city and 1 remote area in New South Wales. And I'm going to focus on that data today. We've learnt a lot from study of these data. It's allowed us to identify how alcohol is priced, the characteristics of cheap alcohol on the market, what helps to drive cheap alcohol, new products entering onto the market that may be of concern, and how taxation actually operates in practice. And I'm going to talk you through some select findings related to each of these. And while I was going to save the policy evaluation for Mia, that's going to be me in a minute. So I'll come back to that next. So let's kick off with looking at how the alcohol market is actually priced in New South Wales. And just for simplicity, for reference, I'm going to be focusing on the data from the remote area of New South Wales, but our papers and reports published and coming cover the full breadth of the data. So what we found may come as no surprise to people here. The most expensive products that are being sold in New South Wales are premix and spirits, generally sold for around or over $3 per standard drink. Wine averaged out to be about $2.50 per standard drink, and then we saw the cheapest beverages being cider and beer, around $2.25 per standard drink. It's not that simple though. So when we look at the variation in price, you can see in particular for wine there is this very large variation in price. So we see wine being sold for under $1 per standard drink through to more than $10 per standard drink. Looking by contrast at cider and beer, it's much, much more concentrated. Now, the colour coding that you can see on the slide denotes the different products by their strength or by their volume. So in the case of wine, when you look at orange, we're looking at products that are sold more than 1 litre. So this is really moving into that kind of cask wine territory. For beer and for cider, that's more your high-strength beer and cider. What you can see across all three of these figures is that the orange is towards that end of the figure, so towards the cheaper end of the figure. And that shows that products of higher volume or strength, they're being sold for cheaper in New South Wales. So let's dig into those cheaper products just a little bit further. This is a question that everyone asks from these data. So what was the cheapest product that we found across the time period? So shown in the yellow is the lowest price that we saw for these products. So cider, cheapest cider we saw was around 96 cents per standard drink, but look at wine. The cheapest wine that we found being sold in New South Wales was 26 cents per standard drink. So what that product was a 5-litre cask wine that contained 47 standard drinks, but that wasn't just a single product as an anomaly. There were quite a number of cask wines around that price point. And indeed, when we look at of all the wine products, nearly 6% of all wine products were priced under 80 cents per standard drink, and around 1 in 4 were priced under $1.80 per standard drink. That was only exceeded by cider, where we saw around 1 in 3 priced under $1.80. If we flip it another way, if you bundled up all the alcohol products together and took the bottom 5%, over 99% of them are wine products. And if you break it down a bit further, nearly 3 in 5 of those cheapest products are larger size, typically cask wines. And they typically originate from southeastern Australia. In particular, we see South Australia featuring quite dominantly there. So how do these cheap products come to be? So other than selling them in these cask wine packaging and taxation, which I'll come back to, there were kind of 2 key strategies that we studied to see how these cheap products were being made possible. The first was volumetric discounting. So this is where, you buy a 4-pack, a 6-pack, an 8-pack, a slab, as compared to buying a can or a bottle, and the discount that you might get with that. So as you would anticipate, the vast majority of premixed products, beers, ciders, they were being sold much cheaper when you buy them in a larger package. But I think it's the price promotion side of things that's quite interesting. So this is, for example, buy 5 bottles, get the 6 free, or save X amount on this product. So what we found was around half of all products were being sold at a price promotion, a little bit lower for spirits. And when we broke it down by volume and strength, it was pretty consistent across the board. So we actually found around 2 in 5 of those larger size wine packages, so those cask wines, were being sold discounted. So this is even pushing down even further the price of these kind of cheap, high-risk alcohol products. We've also been able to study emerging products of interest, including those that may appeal to particular populations, like young people. So you may have seen there's a lot more products around, such as like alcoholic soft drinks or sodas, or things like zero alcohol products as well. So this, for example, focusing in on zero alcohol, we looked at the range of products that were available. This was in 2023 specifically, and we identified over 200 zero alcohol products available across New South Wales at that point in time, predominantly wines, beers and spirits. What's interesting about this is that around half of those products mirrored the branding of alcoholic counterparts. And there's thinking that this is done to reinforce brand recognition, but also to extend that alcohol marketing into settings where you might not normally see it, such as supermarkets, so reaching a different demographic of people as well. On a more positive note though, when we looked at the pricing of zero alcohol products compared to their alcoholic counterparts, what we found was that the zero alcohol products, they were cheaper than the alcoholic versions for the most part. And we could interpret this as being potentially good news for harm reduction in terms of it being cheaper for people to substitute alcohol for the zero alcohol version. Finally, let's have a quick look at taxation. So in Australia, alcohol, just as a quick summary, is taxed under two different schemes. So we see wine and cider, they incur a wine equalisation tax. So they are taxed at 29% of the wholesale dollar amount. Essentially what this converts to is that means that cheaper products are taxed less. By contrast, we see that beer, spirits, premix, they have an excise tax which is done by volume, and that's indexed to inflation as well. So the tax increases with the strength of the product. So when we looked in our data set and we calculated it out, what we can see is that wine and cider are being taxed at a much lower rate compared to other products. So on average in New South Wales, you're paying around 66 cents per standard drink in tax for wine as compared to about $1.65 in tax for spirits. But just to kind of illustrate how the wine equalisation tax really helps, well, seems to help to drive cheaper, high-risk products, we'll just do a bit of a breakdown by volume and strength. So if you look at the kind of cask wine, those bigger wine products, they are taxed at 18 cents per standard drink as compared to kind of your standard bottle of wine that's taxed at 68 cents per standard drink. So taxation goes down as the price is cheaper. By contrast, looking at beer, you can see that as the strength of the product increases, the amount of tax increases as well. So, going back to my opening question about how can these data help us to inform policy, we've shown that there's wide variation in the price of wine, but that a substantial portion of wine is sold cheap, and the large volume wines are sold the cheapest and taxed the least, which is just kind of reinforcing our risk. The wine equalisation tax in its current form, it's actually probably contributing to making cheaper alcohol more available. And this is really an opportunity for us to look and see around different taxation structures that are more targeted around the risk associated with these products and their alcohol content. Secondly, volume discounting and price promotions are widely used, and they're helping to lower the price of high-risk products. We're still doing some work to try and quantify the magnitude of those price promotions, how much a product's being discounted for, but as one possible policy pathway forward, it could be that limiting promotions and volumetric discounts could help prevent these cheap, high-risk products really coming to dominate the market. And finally, we see that zero alcohol products are typically cheaper than their alcoholic equivalents, and maybe this is a positive story in terms of a harm reduction opportunity to encourage substitution. Overall, I think these data, in an ideal world, really we'd be getting access to the sales data from industry. We wouldn't need this data set, but in the absence of that, these data have been very important in terms of identifying levers such as taxation, discounting, promotions that could be used to help reduce harm. So that's presentation number one. So I'll roll into the next one then. All right. If you're happy to bring up. the next one. Great. Okay. So just to really acknowledge Mia and send her apologies that she couldn't be here today, and acknowledge all of the work that she's put into this presentation and these beautiful slides. Okay, so this, as I mentioned, this is another illustration of how we've been able to use these data. In particular, we're going to show you here how we've used it to evaluate the impact of policy, or particularly the repeal of policy and how it plays out on the alcohol market. So this case study is going to relate to the NT, where we've been monitoring alcohol pricing since 2024. So to give you a bit of context about the NT, which I'm sure many of you are aware, rates of alcohol consumption and harm in the NT, they are substantially higher when you compare them to other states and territories. This includes when we look at alcohol attributable hospitalisations, deaths, and so on, all of them much higher. For further context, 30% of the NT population identifies Aboriginal and Torres Strait Islander. That's compared to a national average of 3%. And we know that Aboriginal and Torres Strait Islander people experience disproportionate greater harms from alcohol. So in the NT, while the rate of alcohol-induced deaths is 3 times higher for the non-Indigenous people compared to the national average, for Aboriginal and Torres Strait Islander people, it's 9 times the national average. So there's been a lot of activity in the NT around trying to reduce harms across the population, and a suite of alcohol policies were implemented from 2018, one of which is minimum unit price. As I've already talked about, increasing the price of alcohol, it is one of the most effective ways to reduce alcohol consumption and harm. We know that a 10% increase in the price of alcohol is typically associated with a 4 to 5% reduction in alcohol use. So minimum unit price, it's a policy that increases the price specifically of cheap, high-risk alcohol. Apart from the NT, we've seen it implemented in a few countries around the world, so Armenia, Scotland, Wales, Ireland, and a few Canadian provinces. But NT was the first to implement it and the only to implement it in Australia. So while governments typically use taxation to increase price across the board, evidence suggests that minimum unit price targets cheap alcohol and is very effective in reducing consumption among high-risk drinkers. At the same time, moderate drinkers are shielded from the price increase, as they tend not to drink these types of products that are impacted by the policy. So how minimum unit price works. So in the Northern Territory, the minimum unit price, it was set at $1.30 per standard drink. And this price was chosen very specifically to target cask or box wine. As I mentioned, those wines that are sold in the large vessels containing very large number of standard drinks. So when the minimum unit price was in place in the Northern Territory, this product, for example, would have cost $22.60. with 17.36 standard drinks. So each standard drink has to be priced out at a minimum of $1.30. So meaning even with price promotions, even with discounting, this product could never have been sold below $22.60. So the minimum unit price was implemented in October 2018, and overall it was a good news story. There was reductions in cask wine consumption and alcohol-related harms. And at the same time, moderate consumers were not spending substantially more on alcohol. There was no evidence of negative effects on retailers, tourism, NT economy more broadly. It was generally a good news story. And this was in line with what was seen internationally as well, where minimum unit price had been implemented in Scotland in particular, where there's been these kind of overarching positive effects. However, minimum unit price, it wasn't a politically popular policy, and unfortunately it was repealed on the 1st of March 2025. This is the first time we have seen the minimum unit price repealed globally, so there's no precedent in terms of what type of impact it might have. So as part of the work we were just talking about before, we collected data on the price of alcohol in Darwin from 3 major retailers for 6 months, so from October last year through till March this year, and data collection actually is still ongoing. Our main kind of objective was to see what changes happened in that very first month of the repeal. So we wanted to see how many products came up below that $1.30 threshold in March 2025, how quickly did the industry act, and also to see whether the repeal had an impact on broader pricing trends across the market. So just to give you a bit of sense of what the market looked like in Darwin from our pricing findings, it's pretty similar to what I was talking about before. So we see wine being one of the largest product categories, followed by spirits and beer, and spirits being the most expensive products that we see being sold. So what happened in that first month? Did they leave the pricing alone? No, no, they definitely didn't. So within 1 month of the repeal, there were already 77 products available for less than $1.30 per standard drink across those 3 retailers. These were nearly all wine products except for one cider product. And these 77 products, they counted for 4.5% of all of the listings that we were studying. When you look specifically at cask wine, we found that 75% of the cask wine market, so 24 out of the 32 products we identified, were already back to $1.30, under $1.30 within 1 month of the repeal. So what used to have had to be sold for $22.80 during the minimum unit price came down to about $9, so about 50 cents per standard drink. Looking at AIM2, so what did it do to the broader alcohol market, even just in that first month? So looking at this graph, the dotted lines show the 10th percentile prices for beer and spirits, so meaning 10% of products are priced below this point, so the cheaper end of the market, and the solid lines show the 90th percentile, so showing the price point above which the most expensive 10% of products lie. As I mentioned, wine equalisation tax, specifically for wine and cider, cheaper the product, less the taxation. And then there's the excise tax that applies to other products. And this is actually indexed in line with inflation in February and August in each year. So what we found in February 2025 is that the price of beer and spirits in Darwin rose as expected with this increase in the excise tax with inflation. Normally, after a tax increase, we expect that prices would keep rising the following months. That's what we've seen when we've studied it in New South Wales. However, in the NT, or in Darwin specifically, we saw beer and spirits actually became cheaper in March 2025 after the repeal, at both the top end of the market and at the lower end of the market. So this suggests that potentially the repeal might have driven prices down across the whole market, and not just for those products that were marked that were close to the $1.30 per standard drink threshold. We do need to look at these data over a longer time period though. So to summarise, after the repeal of the minimum unit price, there was an immediate increase in the number of cheap alcohol products available in the market in Darwin, and it was mostly the cask wine. There was also some early indications that the repeal had broader impacts on the market, possibly exerting downward pressure on the price of more expensive products like spirits and beer as well. To determine long-term impacts, we need to analyse this data over time. We also need to see if the market composition in the NT, as well as if there's any changes in discounting and promotions of these cheap, strong products as well. Because by nature of its design, the minimum unit price meant that brands couldn't outcompete on price. They couldn't go any lower than that threshold. And it may have also discouraged brands from introducing new high-strength products into the market and limited discounting and promotions, given they couldn't go below this $1.30. So it may be that those practices start to increase. We also need to look and see what this does in terms of changes in alcohol consumption and harms. But I think this really serves to highlight the impacts of pricing policy and their repeal and how important they can be in shaping the market and harms. Thank you so much.
Thanks, Amy. Of course, Australia was the proud inventor and exporter of the wine in the bag and the box.
Yeah.
So it's going to be hard to move our cultural habits.
Yes.
Certainly pricing is a very important one. Any questions for Amy? We did start a bit late, so we're probably going to finish a bit late. I hope you can bear with us. But are there any questions from the audience? Amy, yes, please. Just wait a minute. We'll get Kamal's coming with the microphone. Thank you. Do you want to just introduce yourself briefly too?
Yeah, good day. I'm Gary Gann from Justice Health. Just wondering, why was the law repealed?
Why was it repealed?
Yeah.
Great question. So, new government, they campaigned, part of their campaign was around repeal of the minimum unit price. They had a number of arguments that they put forward around it. The arguments were that it was disadvantaging certain drinkers, which there was, in terms of moderate drinkers, there wasn't evidence, or other drinkers, there wasn't evidence of that. There was some evidence of an increase in assaults over time. So they made that argument that there was no evidence that it was reducing harms. Actually, it's a bit more complicated than that. Assaults were changing before that, and there was actually a drop in assaults when the minimum unit price was introduced. So it's quite complex to try and causally attribute it to the minimum unit price. And what was the other reason? Oh, they said that it had increased the sale of spirits, of cheaper spirits. But actually, looking across Australia, there's been a broader trend towards greater purchasing of spirits and premix. So again, to tie that to the minimum unit price was a bit of a stretch. Yeah.
And just briefly introduce yourself before you ask your question, if you can.
Hi, I'm Amber from the Public Health Unit in Sydney. I'm a public health registrar. My question is going back to the first presentation, Amy, about the zero alcohol drinks. Maybe they're a positive thing for people that may want to substitute, but then I guess there's always the other side, the introduction of those drinks to young people, which I'm sure you were kind of, I was reading between the lines, but yeah, just I guess if you want to comment to that as well.
Yes. So sorry, in terms of whether we're...
So yeah, in terms of, so you talked about the positive side, so I guess the negative side, so are you introducing young people to alcohol through these non-alcohol, zero alcohol drinks because of that branding? So they're familiar with the brand, and then as they get to the 18 or they then switch to the alcohol.
Yeah, so I think there's research ongoing in that space. I mean, yeah, zero alcohol products, they're being sold in supermarkets and whatnot. I was talking with a colleague who had children who were, as part of a research project, went in and they had these kind of goggles on so they could see what they were looking at in the supermarket. And hey, there's the kids staring straight at the zero alcohol products branded with the alcohol marketing. So that's the risk of that kind of extension is there. And I think, it's zero alcohols are a very complex, and I think complex phenomenon in terms of still trying to get the evidence as to are they harm reduction or are they actually increasing harms and for which population. So yeah, it's an interesting one.
Up the back, Michael's got his hand up. Kamal, thanks.
Thanks, Amy. Fantastic presentation, or both of them. I think you kind of just demonstrated the structural issues in that we try to look for individual solutions, in a sense, for a structural issue. So it's more a comment that yes, something really good did happen. It was a change in the way, the structure and the way in which alcohol is taxed. We had a minimum floor price. That's moved. Now there's all these problems that have re-emerged, and there's government initiative now to look at individual solutions for single person counselling and stuff while not looking at the structure of what's happening. And so thank you for illustrating that quite well.
Thanks, Michael.
Got one last question that will be a quick one to answer from the Slido asking...
I thought you were going to sneak yours in. Okay, yeah.
No, I've got lots, but I'll save them up. From the Slido, so from the audience, have you got any corresponding harms data?
Yes. So we do have a range of harms data, and particularly in the NT, we're quite keen to see what is going on. Obviously, the limitation with these data is that we've got pricing data, but we don't know what people are actually buying. So again, this is where it'd be great to have that sales data or that insight into what people are buying, and then also to look at the relationship with harms as well.
Would there be a legislative lever that we could pull to get the sales data?
I mean, hopefully. I mean, I think I think I'm not the first person to stand in this type of forum and point out the need for these type of data. I think there's a number of challenges there, but so needed.
Excellent.
Thank you.
Thanks very much, Amy. And now we've got our fast and fabulous 4 spotlight presentations. The first presenter is Stassi Kypri, who's a research assistant with the National Centre for Clinical Research in Emerging Drugs and a doctoral student. And his presentation is Insights from the Australian Drug Alerts in 2024, High-Dose MDMA and the Challenge of Alert Thresholds. Over to you, Stassi.
Thanks very much, Nadine. Sorry, I'll put that up. You'll notice the title of this slide is the title of a paper that's recently been submitted, but I'll tell a very brief story as to how we got there. In 2024, there were 47 unique drug alerts issued across Australia, and of these, 15, almost 1/3, related to detections of high-dose MDMA pills. And so this gave rise to some questions. What is a high dose of MDMA? In New South Wales and the ACT, 150 milligrams of MDMA freebase is used as a threshold when issuing alerts. But how does this reflect community attitudes to MDMA dosing? And how do we communicate a freebase dose meaningfully to consumers? We also asked, is this defined threshold useful? How does it help decision making? But could it also inadvertently lead to alert fatigue? Alert fatigue being the reduced response to additional alerts. To answer these questions, we recruited people who issue drug alerts across Australia to a survey and subsequent focus group, and we found that whilst there were some limitations identified, a 150 milligram freebase threshold was widely supported by participants who saw thresholds as enabling rapid response via drug alerts. Without evidence regarding alert fatigue and other direct measures of community perceptions of alerts, our participants also saw little reason to change the threshold. They suggested that a national database of results from analytically tested samples was a way to strengthen future drug alert decisions. And they also thought that educating consumers about the relationship between things like dose and body weight, polysubstance use, and the use of stimulants in hot weather conditions were priorities parallel to drug alerting. That's everything. Thank you.
Thanks, Stassi. We will have a couple of minutes at the end for questions after we've heard our 4 speakers. So if you've got any questions, send them through on Slido or grab the mic afterwards. The next person is Lily Palmer. And Lily, apologies. Lily's with Drug Trends and previously actually was doing the TINA study in Perth. Yep, thank you. Come up.
Thank you, Nadine. Injecting drugs alone is associated with increased risk of overdose, as there is no one present to respond in the event of an emergency. There is evidence to suggest that injecting alone is a common practice, but recent trends in Australia have not been explored, underscoring the need to better quantify and understand this practice. The research aims to examine the percentage of participants in the IDRS who reported injecting alone on the last occasion they injected a drug, the location of last injection among those who reported injecting alone, and the factors associated with injecting alone in 2025. Dr. Rachel Sutherland spoke about the IDRS earlier today, but just to recap, the IDRS involves annual interviews with people who regularly inject drugs from every capital city of Australia and has been running since 2000. Looking at the figure on the left, we identified that between 2020 and 2025, the percent of participants who reported that they had injected alone the last time they injected a drug remained relatively high and stable. Now looking at the figure on the right, in 2025, among participants who had last injected a drug alone, by far and away, the most common location for their last injection was a private home. Multivariable binary logistic regression analyses were performed to determine the sociodemographic, drug use and health factors associated with participants who reported injecting alone the last time they injected a drug. Whilst multiple variables were included in the final model, being male, experiencing a past month injection-related problem, and injecting injecting in a public location, such as a bathroom or stairwell, were found to be significantly associated with higher odds of injecting alone. The above factors are broadly consistent with what has been found in recent literature, though interestingly, injecting frequency in drugs used in the 6 months prior to interview, such as heroin, for example, were not associated with injecting alone. There is an urgent need to consider novel interventions to support those who inject alone and who may be injecting a range of substances. This may include wearable biosensors, which can detect physiological biomarkers characteristic of overdose and facilitate real-time interventions. Overdose hotlines may also be beneficial, which can monitor the caller during drug use and dispatch emergency services if the caller becomes unresponsive. In April 2024, the Victorian Government announced plans to implement Australia's first overdose helpline as part of its statewide action plan to reduce drug overdoses. This year, we included a number of questions in the IDRS asking participants how likely they would be to use overdose hotlines if made available. These findings will be presented at APSAD later this year for those interested. For those interested, please contact us on the emails on the slide. Our national EDRS and IDRS reports were released today, and you can download them from the website displayed. Thank you so much.
Thanks, Lily. Our next presenter is Dr. Nicola Man, who's a research fellow with the Drug Trends group as well. Over to you, Nicola.
Okay, so this study came about as there's a lag in availability of data on hospitalizations and deaths in Australia given the time needed for data collation and processing. Such lag in availability of health-related administrative data is also seen in various other countries. However, the data on wastewater load of drugs can potentially be made available in a more timely manner. So at this point in time, for example, in Australia, our latest data for deaths and hospitalizations goes to around the middle of 2023, which is about 2 years old. Whereas with wastewater data, we have another 1.5 years of more recent data up to October 2024. So in this study, we aim to evaluate the use of wastewater load of methamphetamine to perform near-time forecasting on the rate of hospitalizations and deaths involving amphetamine-type stimulants, the main form causing harm being methamphetamine, and then to evaluate the accuracy of the forecasting. If the estimated data is of adequate accuracy, such forecasting may be used to inform harm reduction responses based on the latest emerging trends. Okay, to do this, we make a time series model on the available data to March 2022. And here we see the rate of drug-induced deaths involving amphetamine-type stimulants up to March 2022. The top graph shows the estimated trend line based on the model with wastewater load of methamphetamine as a predictor in the model. Whereas, and then this is evaluated against the model on the bottom, which shows the model with the data without wastewater data being in the model. And then we forecasted 12 months to March 2023. The results show that the model with the wastewater data is better at estimating the observed data than the model without wastewater. This is demonstrated by the generally shorter distance between the estimated trend and observed data, particularly when we see a change in the trend that may be associated with the wastewater load of the drug. However, when it comes to the estimation of the future rates, it is similar between the two models in this particular study, and we see a similar results for hospitalizations. So the study shows that the wastewater load of methamphetamine can facilitate the prediction of methamphetamine-related hospitalizations and deaths, particularly when there are changes in the trend that can be correlated with wastewater load of the drug. Future work could investigate the utility of such models for other drugs, as well as to use these models to investigate how changes in models and in markets and policies can impact on consumption and harms. And thank you. to my collaborators, funder, and the data custodians.
Thank you, Nicola. And our last speaker is Dr. Danielle Duong Tran, and she's a medically trained epidemiologist with NDARC, and her presentation is, does the use of quit smoking medicines in early pregnancy increase the risk of adverse outcomes for the mother or baby, a multinational cohort study. Over to you.
Thank you, everyone. And first of all, I would like to acknowledge a big team behind this program of work. Without them, the study would not be possible. And in this program of work, we examine 3 studies for smoking cessation, nicotine replacement therapy, varenicline, and bupropion. These medicines are most effective strategy for smoking cessation, but we don't know whether they are safe to be used in pregnancy, so clinical guideline recommends NRT if there's the benefits outweigh the risk of harm, and then if anyone uses NRT should be used under supervision, and clinical guideline recommend against the use of varenicline and bupropion. So in a prior study, we found that varenicline and nicotine replacement therapy, they do not increase the risk of major congenital malformation. And in this particular work, we look at other outcomes for moms and babies, such as preterm birth, emergency cesarean section, severe complication for mom and babies born small size, low birth weight. And with this study, we conducted across 4 countries, New Zealand, New South Wales in Australia, Norway, and Sweden. We analyzed data about birth and pregnancy linked with prescription medicine, hospital admission, and death. We focus on women who smoke in early pregnancy. We examine the outcome in 2 groups, among those who smoke and use any of these medicine if they have up to dispensing in the first half of pregnancy, and then we compare the outcome among those who smoke but did not use any of those medicine. And the 2 groups are matched, so make sure that they have a similar characteristic. And on the right-hand side here, we show the result based on New South Wales, and at the moment, the data analysis in other countries are underway. So let's look at the result for NRT. So overall, about 33% of women who use NRT had any of those outcomes, and the hazard ratio is close to 1. Confidence interval cross 1, no statistical significance. And looking at the individual's outcome, about 9% had preterm birth, 12% had emergency cesarean, and about 12% had baby born small size. And the hazard ratio suggests that there's no increased risk of those outcomes compared to those women who did not use any medicine. And moving on to varenicline, similarly, we found about 32% of women who are using varenicline had any of these outcomes, and there's no differences at all compared to those who did not use medicine. And similar pattern are found for preterm birth, emergency cesarean section, but we note here that we see a higher proportion of women using varenicline having a baby with a severe complication. But I would like to note that the outcomes are only based on 9 babies, and we do many analysis, so that finding might also be due to chance. And over bupropion, we also did not see any increased risk of any adverse outcome for moms and baby, and the number of women using bupropion is quite small, so we're not able to look at the individual's outcome. So overall, what the data tell us that nicotine replacement therapy or varenicline, they were not clearly associated with the increase in the risk of harm, adverse outcome for moms and baby, and given the harm of smoking, so those results are quite reassuring for those who smoke and clinicians for making decision about using medicine to quit in pregnancy. Thank you.
All right, we've got a couple of minutes for questions. Do we have any questions from the audience for any of our 4 speakers? or on Slido, please send them in. I know everyone just wants to get to lunch. But please, if there's any questions, put your hands up. Okay. Well, thank you, everyone. Thank you to Sharon and to Amy and to all of our 4 Spotlight speakers. It's been a really great session. We now have a break for lunch, and we're back here at 1:15. Please don't be late. It will be late at the end of the day. Thank you very much.